Thank you. My name is Dr. Mwogi. My background is in medicine, but I started venturing into the IT world quite early, immediately after high school in '99. I did Turbo Pascal, went into Visual Basic, Visual C++, kept coding through medical school. And only after I came across ERP Next is when I knew I've settled. My journey in ERP Next started in 2018 when I paid a visit to Mr. Mohammed. I think you can just raise your hand there. I traveled from Eldoret to Bungoma to go check, just because just prior to that, as I told you, I'd started a journey through Turbo Pascal and all these other programming languages. And when eventually I was appointed to be the Chief Information Officer of Mwogi Teaching and Referral Hospital, this is the second largest hospital in the country after Kenyatta National Hospital. And in some aspects, actually, even does more stuff than the Kenyatta National Hospital. So when I was appointed to that position, the first task I was given is, see how to change the operations of this hospital. When I had experience with Udo. I had implemented Udo in some private hospital, but it had its own limitation. With its licensing cost, immediately knew that was also the direction to go. So when I Googled about ERP Next, I came across the Bungoma hospital, the Elgon View Hospital in Bungoma. And Mr. Mohammed was kind enough to allow me to go there, where I met him I think he had implemented version 8 or 9 with amazing things. I was quite taken apart at how a system can work in a hospital in such an amazing manner. And therefore, I came back to my hospital and decided that it was time to implement ERP Next. At Mwogi Teaching and Referral Hospital, we are just quite next to Ampath, and I'm glad that the Ampath team is here. Ampath is the source of OpenMRS. The OpenMRS that is now a global open source software started at the same hospital. So my first task was to convince the hospital to switch to this open source system, which was not easy, but it has been quite a journey over the last few years, 4 or 5 years. It's a huge hospital. It's actually a group of hospitals in itself. It is 2,000 bed capacity, but being a public hospital, we're always seeing more than those numbers at any given time. More outpatient visits daily, the largest number of labs that we do in the country, actually more than the Kenyatta National Hospital in a year, and a 13 billion budget, Kenya shilling budget that you have to run on this system. Everything that I've listed there is things that are now running that hospital end to end purely on ERP Next, right? We implemented the entire supply chain system end to end. And it actually has a vendor portal where vendors log in to put in their prices and everything. It's doing the entire financial accounting for the hospital on that entire 13 billion budget. We implemented the HR and payroll. 4,000 staff running a payroll for 4,000 is not that easy, but it's doing it quite well. We were in some process of doing the asset management because the assets in the hospital had never been mapped, and that's actually the process that's taking a lot of time. Our hospital is quite, it's huge in terms of everything. It covers every section that you think you've implemented. The hospital, the healthcare industry has fallen behind technology, not because people are reluctant, but it's because it's extremely complex. It has manufacturing. Running the kitchen and the food service for this hospital is not an easy thing, but again, we are doing that using the manufacturing module on ERP Next. We've implemented a bit of the ISO and quality module as well. And finally, the last 2 years, we've been spending on implementing the healthcare module. So we started actually right from the supply chain to finance and all these others because we needed we needed all these modules in place before you run the patient module. The patient, well, I'm calling it the patient module, but it's the healthcare module. The healthcare module needs everything else in place. It needs the finance in place. It needs stock in place so that you can run your pharmacy and a lot of other things. And So currently, the hospital is actually gone paperless, purely on ERP Next. And you can imagine all those visits daily, all of them are logged in the system. So the performance issues that we were talking about are things that we experienced firsthand as we were implementing this. And I don't know, the one thing that we almost quickly came to notice was that all our documents could not use the naming series, because the way the naming series in ERP Next works is, in Frappe works, is that it locks the database so that it pulls the next number. And we noticed huge performance improvements when we switched away from that. And I would like to hear what the team thinks about that. We also implemented M-Pesa integration so that we don't need to print any receipts. It was quite a mind change that we needed to do to the finance team, because they believed in you have to have a receipt to enjoy service. So we were able to do that. And recently, so this is a government institution. So recently government said, no, all your pay bills, close all of them. Everybody has to use eCitizen. And we had to implement eCitizen, both single sign-on and also payments. I think what has really helped me with the ERP Next is that switching and doing things, because we only have 3 developers in that hospital. They are the ones doing all this internally. And what really has amazed us with the ERP Next is that every time government changes something, we're able to adopt to it way quicker than it would have been possible with any other system. So I'm currently in the process of then transitioning. I was the chief information officer for that hospital, but we are coming to Nairobi because we are the government is evaluating. The current government had the bigger plan of interconnecting hospitals. If you think about it, is that if you go to one hospital, you are seen, and you move to the next hospital, your records should seamlessly move across. So it's a huge project that is about to be implemented in the country. I picked this from, this is a government document, so it has all these types of colors you might not be able to see, but this is now the Kenya Digital Health Superhighway. It is all the components of systems that need to be in place for you to interconnect hospitals. I'll just walk you through a few. For example, for systems to talk to each other, patients have to have a single number that is used across all these systems. So therefore, you need a registry, which is the Kenya Client Registry. All people logging into all systems, whether private or public, have to have a digital ID as provider. So there's a Kenya Health Worker Registry. All the data that is being entered into these systems have to go to a repository that you can pull from. And so this describes that. So that's the National Shared Health Record. And on top of that, we expect patients to be logging in and seeing their records from an app. That's a patient portal, and a lot of other things here. So there was a proof of concept last year, and government mandates another open standard called FIRE to be used. Apologies for that, you might not be able to see that very well, but it's FIRE. Just if for those interested, you need to know that moving forward, all resources, these resources that are going to be exchanged between systems is going to be in HL7 FIRE standard. And in the late last year, the government wanted a proof of concept. We were able to actually do this quickly using ERP Next or the Frappe framework. We build apps across, around it. And had it been any other system, it would have been difficult. And it actually, ERP Next was used as the system to interconnect what is called a primary care network, which is a group of 10 hospitals. We were able to demonstrate in Kericho that you can actually move data across them. And this was made quicker using ERP Next. So how we were able to do it is that every time you see an app, you Frappenize it. It made things easy. Government insists on medical data being within the country. So Frappe Cloud was not an option for us, but almost at the same time when we were grappling with that challenge, Frappe made Frappe Press the app open source, so that we were able to build our own Frappe Cloud instance to run the government apps. So, and that's what is currently working for the 10 or so, what you're seeing there is actually the 10 or so hospitals. and all those systems are interconnected with each other. And with almost 100% uptime. I think that's the beauty with the Frappe press. Docker, everything is on Docker, everything is easy to support. We are hoping that so that we don't need to battle with all this, that Frappe will consider having an outpost here for the Frappe cloud. But it was actually good when Frappe released the capability for you to manage remote, to manage your own, to add your own servers into their cloud. But still, we had already implemented this. So the next step is that government is wants, remember these are only 10 hospitals in one PCN. There are 300 of those that need to be done. So because of the need to scale, we are likely to be going to Kubernetes on the same, but using again Frappe. This is one we've built using Frappe Insights, like the capability for every hospital to log in and see their own dashboards of what is happening. We also have a support portal, again, based on the ticketing system by Frappe. And this is what we are now going on next to having Kubernetes to run the entire infrastructure. Thank you. So yes, the financial aspects of the hospital are not easy. First of all, we developed our own custom apps on this, and especially the healthcare module, we had to change quite a bit to support insurance, especially because a patient can come in and ask multiple insurance, some of them paying multiple ways. So we had to, for every item being added, whether it's a service or what, we use the what do you call them, the customer groups, as almost like the insurance. And then, but initially that's what we had used, but we immediately realized that a patient has a customer, but a customer can have multiple insurance. So that didn't quite work initially, so we had to customize a bit. And when we also removed the need for you to generate invoices immediately for a patient. What happens is we created a doc type called charge sheet that you generate a charge sheet, and for each charge sheet you allocate, because some of them are co-payments, an insurance is paying a bit and the other one is paying this much. And therefore, when you have all these charge sheets, at the end, let's say at discharge, you generate now a sales invoice document. And in that sales invoice, you apportion, you do the apportionment. So it will be one sales invoice of, let's say, 10,000 shillings, but there is apportionment to say NHIF is paying this much, the patient himself is paying this much, and another insurance is paying this much. That one invoice is sent to the multiple insurance, and each insurance will know the bit they need to take care of. Something like that, yeah. It's a good one, and I think this one, I'm sure everybody has their own experiences. What I've noticed works is management, like from the top. You have to have a top-down support for the system. I ran into a lot of resistance here because I had just been appointed Chief Information Officer. You talk to someone in supply chain, no, that's not how we work here. We have this law that does what, this is how things are done. So it needed a bit of push right from the CEO of the hospital. He's the one who was like, I want it done by this date. And then being a public hospital, what we also did, we entrenched it into the performance contracts of everybody. So it's more of management than anything that ensures things actually flow down. It's a bit of that, it's a bit of carrot and stick, reward for those who work, and for others, it's really a stick first until things work. What helped us, and when we implemented this system because as I told you, this hospital is big. It's actually a group of hospitals in itself. We started with the children's hospital, and the one thing that happened, because even the team from finance were a bit resistant, the revenue shot 4 times, right? We used to make 10 million Kenya shillings a month to 40 million. And then suddenly, there was a whole meeting called to say this system is overcharging patients. And then we had to go through reports to realize that it's not, we're just making more money. Now, that's when there was there was a switch, there was a mindset switch to say, you know, this works, so why resist it? Yeah. So I think it's a combination of things. Yeah, thank you for that question. So currently in the country, there are two main, well, each of these insurance companies have their systems that most of the time you turn up, someone has to log in and check your insurance details using your ID, right? And that's what actually happens most of the time. Even for us being a public hospital, most of our patients are on NHIF. There is not a good integration currently with insurance companies, but this superhighway mandates that there will be an e-claims management service hooked into this, and that everybody will be using this superhighway to submit your claims, where it can then be, so even if you turn up, your verification is first of all logged in into this, and it will be linked to the client registry. The client registry will have things like biometrics and other things integrated with it. So to answer you, currently there is not a good way of doing it. One of the things that amazed me when I went to Bungoma that time, and maybe I'm going into your talk for the afternoon, but one of the things that amazed me, it integrated with CCTV, that TRP next instance, it's such that if you turn up and then you say your NHIF, as soon as they register you, used to be a photo that is attached to your, because one of the frauds that used to happen is that I turn up and say I'm so and so when I'm not, just so that and sometimes when relatives give each other IDs to use, and I think he got a few people there who were trying to beat the system. So currently we don't have but there's integrations going on with a number of platforms that are the main providers for insurance. Which can also be integrated, and we had built it. What we had done, and we also adopted this from Mohammed, is that we used, what do you call it, the app for scrubbing. It automatically logs into NHIF and checks you and pulls your details, including your photo, and puts it into ERP next, so that you can quickly see your face and see if it's you, and other things like that. I think I've forgotten it, but we did it, and we, Beautiful Soup there. Yeah, we used Beautiful Soup for that. But only the problem with it is that every time NHIF changes their HTML somewhere, you run into problems. Yeah. Yeah, thank you. We build a queue system on Frappe as well, with a customized page that just lists the next. And if a doctor says you're next to be seen on the queue, it kind of displays on the other end, something like that. We ran into problems because of procurement. We needed screens all over the hospital being huge. The truth is we are really not using it at scale, but it's available. An alternative is to integrate with the queuing systems as well. That's an alternative. But you have to procure and then hit some license costs there. It's an alternative if you're in a private hospital that can work.